Hello. Alright, today I am going to be presenting a case presentation with a simple objective in mind. That is to be familiarized with how to present history and present physical examination finding in long form. And I'm going to point out a few important things as you go about doing that in terms of what the case is and how you should be looking for certain symptoms and how you should be looking for certain signs and anticipating to make sure that you get proper findings, and that will be good for your examinations and certainly good for your clinical skills. So let's go ahead and start. So this presentation is of a 78-year-old lady of West Indian origin presenting with a 4-week history of diarrhea, progressive abdominal swelling, as well as shortness of breath and poor mobility over the same period. This is a case that's going to be optimized for the objectives that I mentioned. It's a case that I got from the Cases Journal, published in 2008. So it's a case report, but I added a few things here and there, aided by studying the topic properly from MKSAP, 16th edition. And so it is not a real case, but it's going to do us wonders in terms of grasping what it is that we want to grasp. So the lady denies any fever, any night sweats, jaundice, vomiting, or foul-smelling stool. There are no changes in stool color, urine color, or stool habit, or urine habit. She's hypertensive for over 10 years, she suffers glaucoma, and she's well-controlled type 2 diabetes mellitus. Now, it's very nice that I get to know that it is controlled diabetes mellitus, but remember, glaucoma can be a complication of diabetes mellitus, or anything that causes neovascularization in the retina and in the optic area, and that could cause closure of the angle causing glaucoma. But certainly a fundoscopic examination would be wonderful to tell you whether or not it is related to diabetes. And of course, hypertensive sequelae of on the retina are also important factors to consider. I am hoping that I will be giving a presentation about that specific topic soon enough. So I'm going to go ahead. She is on benrafluozide, gliclazide metformin, thiazide diuretic for hypertension, sulfonylurea, and biguanide respectively, the latter two for diabetes. There are no known food or drug allergies, and no family history of note. She's a retired university professor. It's always good to know that she's a lady who is not doing a lot of severe labor. She's retired. She's in good socioeconomic status. It's actually also important to know how she spends her time. Is she just sitting at home? Is she depressed? Is she happy? Is she sad? Does she feel satisfied? How her outlook on her life was. So all important things, because if a patient is depressed, then that means that they cannot cope with their symptoms as much as a patient who is feeling good about themselves. So this is also a note to keep in mind when you are asking any history, especially when it comes to family and social history. So in this instance, the lady is doing well, living with her daughter. She's quite happy. She did not travel in the last 5 years. Last time she traveled 5 years ago was to India. And there's no history of animal contact. She is postmenopausal, long time ago, and she's para 4 plus 2. We don't have specific detailed history about the plus 2, but it would be nice to see if there was a history of any autoimmune disease. However, she denies having any significant medical history other than her diabetes and hypertension, and then off late, her glaucoma. Review of system is insignificant. Now, when you're asking about the review of system, you should go systemically. There are certain presentations and definitions, they're vague. A patient coming with abdominal distension, it may be a good idea to go ahead and ask, so when did that start, what happened, and ask all the questions related to the presenting illness and take a history of the presenting illness. And then in some references, they tell you the review of system should be immediately after the presenting illness. And in other references, they tell you the review of systems should be left till the end. If left till the end, good and well, but I think you should be more dynamic. So if you have a vague presenting symptom, like, oh, abdominal distension, oh, I'm not really sure when did it start, it's a smart idea to put the review of system immediately after presenting illness. It even makes more sense as you are taking history from the patient, because any positive in that can lead your conversation. This lady is fine, and going on to the physical examination, her vitals are okay. She's afebrile, blood pressure is fine, pulse is 87, respiratory rate is 19, and saturation is 92 in room air, or 98, I apologize. Her head, ear, eye, neck, and throat examination is also insignificant. There are a few things that you should know, and I took a template because the case doesn't have a detailed physical examination. And one of the things I did was I used Nicholas Staley's textbook to give myself a template on how to take histories as a medical student and an intern. And then I found myself a nice template from Stritch School of Medicine, Chicago. And they have a wonderful template of the normal findings. So you put it there and then you start changing as you find any abnormalities. And it's important to be familiarized with the formal way of presenting your findings and not use any terms. And note, keep in mind, different references will have different use of terminology or different ways of presentation. You should be familiarized with one thing and stick to it and become very, very good at it. So I'm sticking with this with most of my presentations. And so we did a fundoscopic examination to rule out any diabetic sequelae, which could also be related to to say problems in vasculature elsewhere in the body, to atherosclerosis, to renal artery stenosis, to kidney issues, which could lead to distended abdomen, although unlikely in this case. Sclero is white, conjunctiva pink. The rest of the fundoscopy is fine. And the neck, one thing you want to keep in mind, remember in the extremes of age, a patient with infection might not come with fever, and if they come with fatigability or some vague symptoms, keep in mind that you must rule out infections. It's good to do a CBC and culture, full septic screen if you think it's warranted by taking a urine sample, a blood sample, maybe even a nasal swab and a throat swab. So in her case, the flexion is fine in all areas, and that rules out meningitis. And the trachea is midline, mobile, and in a normal way. The thyroid was non-palpable in this case. There is a variant of thyroid that may be palpable. Keep that in mind. Normal size and consistency and no lesions. Suprasternal notch shows no pulsation. An aortic pulsation can give an idea of an aortic arch aneurysm. There are no palpable lymph nodes. The chest inspection, thorax and back, they look fine. There are no scars. There's no sign of a previous surgery, a midline scar as such. And the expansion is symmetrical with the respiration. The other finding, the only actual finding, is a fine inspiratory phase crepitation audible in bilateral lung bases. Now you should start thinking, I have a patient with fatigability, with distended abdomen, and shortness of breath, and that explains the shortness of breath. There's an actual finding, and I'm hearing fine inspiratory phase crepitation, which probably tells me that there is some parenchymal edema at the bases of the lung. And best heard from the back. The neck veins, there's no jugular vein distension at a 45-degree angle. Always document the angle. It's important. Some people do it at a 30 degrees. Some people don't actually document the angle. They just raise the bed a little bit and do it. If you're an expert, that's fine, but keep in mind in a formal examination, an appropriate technique is important, and mentioning the degree is simply very important. Carotid arteries, you should also try to palpate these, see the amplitude and the contour of the arteries, the pulse, is it equal bilaterally, and that gives you an idea that it is okay. And auscultation of the carotid is also important because a Brewy can tell you that there is some constriction, and constriction means that there is a little bit of atherosclerosis. Looking at the precordium, so as you see, I did inspection in general, and I am looking, and then I started to do my palpation, physical examination in a systemic way. Inspecting the precordium, there's no lifts or heaves, and no parasternal impulses, no thrills. And then I go ahead to my auscultation of the heart. First and second heart sound are there. Splitting, inconsistent. It's not splitting that is there with every beat, but when it is there, A2, the aortic valve, is louder than the pulmonic valve, and there are no extra sounds. Keep in mind, a fourth heart sound in the age of our patient is not at all uncommon. Now look at the way that I am presenting my findings. I don't actually examine my patients in one system organ and then the other. What I do is inspect everything at once. I'm inspecting the chest, the expansion, the back, and the precordium, and I'm looking for thrills and heaves and everything when I'm looking. And when I ask the patient to sit up, I examine the back, and I even look for sacral edema right there and then, and do whatever I need in the back, because you don't want to keep lifting the patient and making the patient butt. What I'm trying to say is, I am not compromising my examination by trying to lump everything together. You have to be very organized. Grossly distended, intense abdomen. There are no scars. Old striae are visible. Auscultation, normal bowel sounds. 3 per minute, 1 to 3 are normal. No bruise. And on palpation, there is no shifting dullness, or a slight shifting dullness, but with a thrill. It's important to understand the difference between shifting dullness and a thrill. That tells you there's a fluid, but it's not a lot of fluid. The other tells you that there's so much fluid, shifting doesn't matter, but the moment you tap the abdomen, you see a thrill moving across the abdominal wall, especially if a patient doesn't have a lot of adipose tissue. In that case, it'll be very visible, and you're going to see a water thrill going from one side to the other, and that gives you a good idea of the amount of fluid that is accumulating in the abdomen. So this patient does not have so much fluid. There's some fluid, and that's very visible by shifting dullness, and you do that by percussion. You percuss, you find dullness in one area and resonance in one area, then you ask the patient to shift, and that distribution changes, which means fluid, which moves with gravity, has shifted. Liver was unpalpable and spleen is not palpable. Note that when you have fluid, you may not palpate, you may not be able to palpate. When you have distension or a mass, or when you have massive ascites, that could also obscure your palpation. If you have a solid mass in the abdomen, that could mean obscuring your idea of where the edges of the liver and spleen are, but you're gonna find the mass by doing your examination. One more thing, by a lot of practice, the consistency of the liver and the consistency of the spleen are something that you're going to pick up on. So even if there's a mass that's literally touching the border of the liver or the spleen, or even pushing them up towards the costal margin, you may still be able to tell that that's a mass, an intra-abdominal mass, such as, say, fibroids in a younger woman, and that's the liver. But that takes a lot of practice, so it's not enough to just read. It's important to actually examine. There are no sacral edema. Femoral artery pulses are equal bilaterally. No hernias, and rectal examination shows watery mucus. And no masses otherwise, excuse me. Looking at the extremities, there are no cyanosis, clumping, and normal texture and color of the hands and the nails. Now, that may be part of your general examination. In this case, I prefer to put it under upper and lower extremities, because examining the extremities gives me an idea of the level of edema, if there was, because now I'm suspecting that there is either a cardiac or a liver issue. Not as much kidney issue, but it could still be possible, because these are the 3 organ systems that can give me intra-abdominal fluids, plus this patient also has evidence of fluid in bilateral bases of the lung. So yes, indeed, there is bilateral pedal edema, and the rest of the extremity examination is normal muscle size and tone and range of motion, and there are no tender points, etc. So this patient has a grade 1 or a plus, which is both feet and ankle. Please note that in this specific system, which is a table that I took from Wikipedia, not a smart idea to do in any formal examination, but it's because I know this information is accurate, so I'm putting it here. The grade plus can give you what is also known as anasarca. I want you to know that there are other grading systems for edema, but that's not the topic of discussion at the moment. Neurological examination. This patient told me she's fatigued. And if a patient is fatigued and old, and she was coming in the room or in the ER and she has a slow gait, as I conveniently put there, it's always a smart idea to do a proper neurological screening. Now, I'm not telling you to spend half an hour doing a neurological exam, but getting very familiarized with my cranial nerves, how to examine the extremities, and how to examine touch and power, and then how to see a patient walk, that gives me a good neurological screen. And if everything is normal, I don't need to do anything more. Now, if there is an abnormal gait, maybe it's a good idea to do further tests like a Romberg test or cerebellar tests, whatever they are, a number of tests. Or if there's whatever abnormality from the top to the bottom, then you go and investigate. But doing a neurological screen is not hard. Take the cranial nerves from cranial nerve 1 to cranial nerve 12, which is XII. And the first is a nerve, the olfactory nerve, is not really testable unless you just bring something for the patient to smell. But I'll take the patient's word on it. Oh, I smell fine, I taste fine, and that's fine. Your optic nerve and the rest of your oculomotor nerve, so the second, the third, the fourth, and the sixth, you do the following. Use your torch, look at the pupillary reflexes, and do crude perimetry. Are you seeing my fingers? And if they see it up and in all parameters, and please refer to the appropriate way of doing that and how to cover one eye, then cover the other, and that's called crude. It won't take you 2 minutes to do. And then you just ask the patient to follow, and if all the extraocular movements are fine, there I go. I just knocked 4 cranial nerves down. Then my 5th and 7th nerve are quickly examined by asking the patient to grin and to protrude their mouth and to swallow and to feel everything is fine. And then I move on to test the rest of the cranial nerves other than the 8th, which is the vestibulocochlear, which I'll come to right now. There's a gag reflex. As I said, there's a swallowing. They can raise their shoulders, and even against resistance, everything is fine. And by quick look, by looking at the face, there's no issues, there's no asymmetry, there's no deviation of the muscle to one side, showing that one side is stronger than the other, indicating that one side has a palsy. And finally, the vestibulocochlear nerve, which is the 8th, can be, well, you can do a crude testing as well that won't give you very accurate details, but can she hear? Yes, she's responding. That's fine. You can rub your fingers on both sides and ask the patient which finger is rubbing and moving both hands, but rubbing one at a time. And that gives you a good idea. Our patient is normal. Wonderful. Let's move on to the investigations. So she is anemic, and MCV and MCH are fine. So this is a normocytic, normochromic anemia, most likely indicating chronic disease. RDW is 14 within the normal. It's also good to see the reticulocyte distribution width. There's no high platelets, so there's no reactive thrombocytosis. So I'm not suspecting inflammation. It's also good to have ESR and C-reactive protein. And the coagulation profile is normal. The albumin is 28, a little low, with an ALT and GGT, which are ALT and ESD tell me an idea of hepatocytes. ALT is not very specific and sensitive to those. AST is more so. GGT is very specific and sensitive to the bile ducts and ductules. So there definitely is a ductal issue in the liver, not as much parenchymal. And ALP usually should be high, as we know from medical school. And this is just something to spice up the case a little bit. It should be high if you have a ductal damage, but this one is normal. And normal thyroid functions. Now, a tap of the acidic fluid was done, and whenever you try to assess ascites, you should do the following. You take the sample and you look at it. You inspect the sample. If the sample color is weird, then there's a problem. By weird, I mean murky. This was clear and yellowish, and that's the normal. So that tells me that there's no infection and there's no pus. You should also do a cell count analysis. 460 WBCs and less than 190 polymorphonucleosides per micro. 500 and 200, if I remember correctly, are the cutoff. So as the cutoff for abnormal. So these are normal findings. And then you do the SAG, which is a ratio, the serum ascites albumin gradient. How much albumin is in the serum over how much albumin is in the ascites, and 28 to 26.8 is the ratio in our case. So it's 28 in the serum and 26.8, and the ratio is 1.2. Total protein is less than 2.5. 2.5 actually is the cutoff between exudative and transudative. So I'm not going to call it exudative. I'm just going to say it's the cutoff of normal. Negative culture and gram staining and cytology. So 1, 2, 3, 4, 5, 6. You should always do these 6 analyses whenever you have an ascitic fluid. CT scanning revealed that there indeed is hepatosplenomegaly, which I was not able to elicit in examination. An echocardiogram shows a moderate diastolic dysfunction, which could raise alarm, but I know the patient is old. And then in this case, I want to look at the ejection fraction, which they conveniently left out because they don't want to discuss a cardiac issue, but let's say it's above 55 and call it a normal. So an echocardiogram is normal-ish for age. Further tests, the gamma globulins show polyclonal increase in the normal IgM fraction. So IgM is an acute antibody, and polyclonal increase means that it's attacking a certain something. There's memory against a certain something, and that something in this case is most likely the body's own tissue, because the patient is vitally stable, and ideally I should have done septic screen and everything is negative. And with a strongly positive anti-mitochondrial antibodies, I right away know, okay, there is an autoimmune process. And even a positive anti-nuclear antibody staining, and in this case in a centromeric pattern. I plan to discuss rheumatologic findings in a later presentation, but in this case, a centromeric finding with anti-mitochondrial antibody, which is highly sensitive and specific for primary biliary cirrhosis. So I am almost sure of the diagnosis at the time, even though alkaline phosphatase should be high. But it's not, but let's rule out any doubt by taking the histology, taking a biopsy. On histology, there's an intermediate magnification of a micrograph of a histologic section is shown here, and it's telling us that this is a picture of primary biliary cirrhosis showing bile duct inflammation. See the periductal infiltration, this is the duct, and then there are granulomas. And this distribution of granuloma, ideally it should be like this, around the duct. It's called the florid lesion because it looks like a flower. So the diagnosis was finally made, and the patient was started on the best treatment we have to control the symptom and progression of the disease, which is ursodeoxycholic acid. By the way, urso means bear because this specific bile acid is found in bears, and ursodeoxycholic acid shows intestinal byproduct of bile metabolism leading to less absorption of cholesterol. In summary, this is a 78-year-old lady presented with abdominal swellings and fatigue, anemic, hypoalbuminemic with normal alkaline phosphatase, which is weird, and CT showing hepatosplenomegaly with mild ascites, antimitochondrial antibodies strongly positive, and the diagnosis is primary biliary cirrhosis. Let us discuss that, shall we? Before we wrap up this presentation, it is important to know that primary biliary cirrhosis is presumed to be an autoimmune disease of the liver, which is most commonly diagnosed in women between the ages of 30 and 65. In the modern era, most cases are diagnosed when asymptomatic, usually presenting with abnormal LFTs. Symptoms can include fatigue, pruritus, rheumatic symptoms, skin hyperpigmentation, and right upper quadrant pain. The antimitochondrial antibody is the serological hallmark of the disease and is present in the serum of nearly all affected patients. Likewise, the serum alkaline phosphatase level is almost always raised and often to striking levels. Treatment is aimed at alleviating the symptoms and complications of the disease and attempting to suppress the continuing destruction of small bile acids or small bile ducts. Ursodeoxycholic acid, or UDCA, may work by suppressing release of endogenous bile acids, which are toxic to hepatocytes, and it also inhibits eosinophil activation, which may have a pathologic role in primary biliary cirrhosis. Ursodeoxycholic acid at approximately 13 to 15 mg per kg as a dose per day has been studied extensively in individual trials and has been the subject of at least 3 meta-analyses. Results of these are conflicting, but considering the results of the individual trials, the few effective available alternative treatments for patients with primary biliary cirrhosis, and the excellent tolerability of ursodeoxycholic acid, it is still widely considered first-line therapy. Be careful, clinical judgment is warranted. This case is unusual for several reasons. The patient was diagnosed at an older age, and than is usual, and she had unusual presenting symptoms with ascites as her chief complaint. Most important, this case highlights that primary biliary cirrhosis can exist with an entirely normal alkaline phosphatase, and here the diagnosis hinged on a high index of suspicion and an elevated gamma glutamyl transferase, which warranted the physicians to go ahead and order the antibody screening even at an older age. Autoimmune diseases usually come in women at younger ages, so this is also wonderful that it was thought of by the physicians who are treating. These are my references. Thank you very much for listening.